Good morning. Are you able to see the PPT?
Yes, sir.
Okay. So today's class about the X-rays and instruments in ENT. So usually you'll have the in the practical examination you will have the X-rays for 5 marks and the instruments for the 5 marks. So these two 5 marks and 5 marks will be added to the even final Viva marks. So it will be added to your theory marks also. So the X-rays and the instruments are very important. So today's class is X-rays in ENT. So first of all, immediately after seeing the X-ray, don't jump into the directly to the diagnosis. You have to read the X-ray. So for proper reading of the X-ray, they'll give the marks. So X-ray, and finally you have to come to a conclusion of the diagnosis. Then you should tell the probable diagnosis of the that X-ray, particular X-ray. You should talk about the particular X-ray. Don't tell in general. So you have to tell the findings in the X-ray and the provisional diagnosis, and then they will ask the what is your treatment for that particular provisional diagnosis. So you have to tell the management of that diagnosis. So reading of the X-ray is important. So how to read an X-ray? First you should see the X-ray whether that is plain X-ray or contrast X-ray. Then which part, the part of the body you should mention in the X-ray. So you should read the part of the body, which part of the body you are seeing in the X-ray. Then what is the view? So which view you are seeing, AP view, like AP view, lateral view, PA view, like that you should read the view of the X-ray. So first plain X-ray or contrast X-ray, which part of the body and which view. And then findings in the X-ray. So whether that is normal X-ray or is there any abnormality in the X-ray, then provisional diagnosis. So like this you have to read the X-ray. So don't tell the diagnosis. If you know the diagnosis also, you have to read the X-ray in a proper way. So these 5 points are important while reading the X-ray immediately after seeing the X-ray. So whether that is plain X-ray or contrast X-ray, which part of the body and what is the view, AP view, PA view, lateral view or oblique view, then findings in the X-ray, then provisional diagnosis. So then they'll ask you what is the management of that particular condition. So this is the X-ray. So X-ray of the mastoids. So this is plain X-ray, lateral oblique view showing the mastoids. Lateral oblique view showing the mastoids. Both two X-rays you are seeing here. This is right lateral oblique view. The other name for the lateral oblique view is Collard's view. Collard's view or the Law's view. So you have to remember the views, names of the views also. So this is the lateral oblique view of the mastoids on both the sides, right side and the left side. So how will you say whether that is right or left? You should see the marking over the X-ray. This is very important point you have to remember. So first you should see the marking over the X-ray. So this is the right side. This is showing as a P, but it is wrong. R or L. So immediately over the X-ray you should observe the marking. So whether that is right or left. So marking is important. So this is on the right lateral oblique view. This is the left lateral oblique view. So on right side you can see this is the external artery canal superimposing over the internal artery meatus, and this is the external artery canal, and this is the you can see the honeycomb appearance. So this entire part is the pneumatized mastoid antrum. So if you see the honeycomb appearance, that means that is a cellular mastoid. So usually cellular mastoid appears as a honeycomb appearance in the X-rays. So this is the external artery canal. This is the mastoid part. This is the sinus plate. This is the tegment plate. So tegmen, mastoidium, and this is the sinodural angle. So immediately above the tegmen plate, there is a middle cranial fossa dura, and this is the junction between the sinus plate and the dural plate. This is the sinodural angle. Okay. So if you see the honeycomb appearance and cellular mastoid, that means that is a normal mastoid air cell pneumatization. So if you observe, if you compare these two X-rays, this is on the left side. So there is no honeycomb appearance. This is the sclerosed mastoid. So this is the external artery canal, and here you can see the temporomandibular joint. This is the TM joint. This is the angle of the mandible. Here you can see this is the temporomandibular joint. Okay. So this is the external artery canal. This is the sclerosed mastoid antrum. So sclerosed mastoid antrum we'll see in case of any mastoiditis. So if there is a chronic infection and inflammation within the mastoid air cell system and the mastoid antrum, so then you will see the sclerosis or haziness of this pneumatized mastoid antrum. So if you see this kind of mastoid system in the X-rays, that means that is a mastoiditis. So chronic mastoiditis. So then they'll ask you, what is your provisional diagnosis? You have to tell the finding, then provisional diagnosis, then the treatment for that particular condition. So this is a plain X-ray mastoids, right and left lateral oblique view. The other name for that lateral oblique view is this Colors view. So cellularity of the mastoid air cells on the right side and sclerosis on the left side. Provisional diagnosis is the chronic left-sided mastoiditis. So treatment for that chronic mastoiditis is mastoidectomy or mastoid exploration. So we need to drill out all the accessible mastoid air cells, see the condition. So intraoperatively we'll decide whether we have to do the canal wall up mastoidectomy or canal wall down mastoidectomy. So depending upon the pathology within the mastoid antrum and the middle ear and the attic region, then we'll decide whether we should go for the canal wall up mastoidectomy or canal wall down mastoidectomy. So these are the other frequently asked questions in the. So why do you take a X-ray? What is the importance of the X-ray before surgery? And what are the different views for the temporal bone? And what is the common view for the mastoids? Various types of the mastoids. So that means scalular, diploic, and the sclerotic. So what is mastoiditis? What is coalescent mastoiditis? How do you manage? And advantages of the CT scan of the mastoids over the X-rays. So in CT scan, you can see all the minute details compared to the X-rays. X-rays, you can see the only boundaries and the haziness, so that we can know whether the mastoid antrum and the air cells are involved or not. In CT scan, you can read the CT, you can see the minute details of the mastoid antrum and the air cells, vascular status, any necrosis of the sinus plate, dural plate, vascular erosion, facial nerve involvement, any erosion of the bony canal over the facial nerve, all those minute details. If you are really planning for mastoidectomy, the better investigation is the CT scan of the mastoids. So these X-rays will act as like a screening procedure, so that we can come to a conclusion whether mastoid antrum is involved or not by the disease process. Okay, that is about the X-ray of the mastoid. X-ray mastoids, lateral oblique view or Scholars view. The right and left, usually we should take both the sides, right side and left side, compare both the sides, decide whether mastoid antrum and air cells are involved or not. So next, coming to the second X-ray, that is the paranasal sinuses. So this is also again a plain X-ray. Plain X-ray. This is Waters view. This is called the Waters view or suboccipitomental view with open mouth. So usually we'll ask the patients while taking the paranasal sinuses X-ray, will ask the patient to open the mouth. So this opening of the mouth will helpful to see the sphenoid sinus. If you observe clearly here, there is a sphenoid sinus within the open open mouth, you can see this is the intersphenoidal septum, and this is the entire sphenoid sinus. This is the nasal septum, and this is the frontal sinus. So this is very well pneumatized frontal sinus. These are the boundaries or walls of the frontal sinus. So normally the walls of the frontal sinus will be like this. This is called the scalloping of the frontal sinus. So this is a normal finding. This is not the abnormal. And this is the interfrontal sinus septum. Intersinus septum. So this is the maxillary sinus on the right side. So again you should see the marking over the X-ray. This is on the right side. This is over the left side. So if you compare both the sides, maxillary sinus, here you can see the haziness. On left side, left maxillary sinus, you can see the haziness. So this spot is the again mastoid antrum and the air cells. Well pneumatized mastoid antrum and the air cells. This is also you can see. This is the open mouth. Here you will see the ethmoid sinus and the ethmoid air cells. So you can't see clearly the ethmoid air cells in the X-ray of the paranasal sinuses. So this is the plain X-ray, Waters view or suboccipitomental view with open mouth of paranasal sinuses. So you should read the X-ray. This is X-ray of the paranasal sinuses. This is not the skull X-ray. Okay. So this is X-ray paranasal sinuses. Plain X-ray paranasal sinuses. Waters view showing the haziness in the left maxillary sinus. So your provisional diagnosis is the sinusitis, left-sided maxillary sinusitis. So then they'll ask the treatment for that sinusitis. So what are the other views for the paranasal sinuses? These are the related questions in the Viva. So what is the view with the open mouth? Open mouth is for what? So that is for the to see the sphenoid sinus. So other name is the suboccipitomental view. Air fluid level seen in the acute sinusitis. So suppose if it is a disease is acute process, acute sinusitis, you will see the clear-cut air fluid levels within the maxillary sinus. If you are seeing the uniform haziness involving the entire maxillary sinus, that means that is a chronic disease. So after giving the adequate medical treatment, if still patient is complaining of symptoms, then we will take the X-ray or CT scan of the paranasal sinuses. If the disease is present more than 6 weeks, then we call it as it is a chronic sinusitis. So the definitive treatment for this chronic sinusitis is surgical treatment. So after giving the medical treatment, then only will take this radiological investigations. So if they ask treatment for chronic sinusitis, your answer should be functional endoscopic sinus surgery. Don't tell medical treatment again. So in chronic means already you have given the medical treatment, adequate treatment. If the symptoms are not subsided with the medical treatment, then we should take this X-ray or CT scan. So chronic sinusitis treatment is functional endoscopic sinus surgery. And where do you see the destruction of these walls of the paranasal sinuses? In case of malignancy, you will see the destruction. So if you see any erosion of the bony walls of these paranasal sinuses, definitely you should suspect the malignancy or fungal sinusitis, invasive fungal sinusitis, benign or malignant tumors of the nose and paranasal sinuses. So this is third X-ray, X-ray of the nasal bones. This is again plain X-ray showing the nasal bone. This is the nasal bone. Here you can see the discontinuity in the bone. So this is again lateral view of the nasal bone. So this is again you should see the marking over the X-ray. This is the L for left side, left lateral view. This is the frontal sinus. This is the frontal sinus. This is the nasal bone, nasal septum. This is the tip of the nose. This is again on right side, right lateral view. Maxillary sinus, frontal sinus, nasal bone. So nasal bone is very thin at the tip of the nasal bone. So usually you will see the discontinuity. Usually all facial injuries most of the time it is involved during the trauma, the most commonly road traffic accident. So plain X-ray skull lateral view showing the nasal bones right and left. So there is a fracture discontinuity in the bone, that is called the fracture of the nasal bone. Treatment for this fractured nasal bone is the correction under general anesthesia. Correction or closed reduction under general anesthesia. That is the treatment for the nasal bone fractures. So these are the other related questions to the nasal bone fractures. Classify the fractures of the face. What are the symptoms and signs of the fractured nasal bone? So most of the time, if the nasal bone fracture is undisplaced, only hairline fracture is there without any symptoms, then no need of any treatment for this hairline fracture of the nasal bone, because it is a immobile bone. So the most common symptoms are the external nose deviation or external nose deformity and nasal obstruction. These are the two common symptoms with the nasal bone fractures. So if the patient is complaining of any nose blockage or external nose deviation, then you should go for the surgical treatment, and that too most of the time in simple fractures, that is will done by the closed reduction. Can anyone tell the what is the instruments which is used for the nasal bone fracture? Last class saw told about the instruments. Roll number 42. Instrument which is used for the fractured nasal bone. Students, 26, roll number 26. Roll number 24. I am marking absent those who are not answering. '74. Roll number 125. Abhishek Gaud. Abhishek. Roll number 5. Roll number 6. 7.
Sir, present, sir.
7.
Yes, sir.
Yeah. So what is the instrument which is used for the correction of the fractured nasal bone?
Correction of nasal bone, sir.
Instrument. Which instrument will use for the correction of the nasal bone fracture?
Walsham forceps, sir.
Yeah, very good. What is your name?
Akhilesh, sir.
Akhilesh.
Akhilesh. Roll number 7.
Yes, sir.
Okay. Last class, sir told about the instruments.
Yes, sir.
Okay. So that is the forceps which we will use for the correction of the fractured nasal bone. If it is causing the any symptoms like external nose deviation and the nose block. So other questions are the what is open book fracture and what is closed and the open reduction. So those are the other related questions. So this is the other X-ray. X-ray skull lateral view showing the nasopharynx. Here you can see the arrow mark and haziness in the nasopharynx. So this is the roof of the skull and this is the posterior wall. So in the nasopharynx, at the junction between the roof and the posterior wall, there is a haziness. So probably the diagnosis is adenoid hypertrophy. And if you observe the size of the skull, it is a pediatric patient. So that is also important. Usually you'll see the adenoid hypertrophy in the children. So this is again like this. You have to read the plain X-ray skull, lateral view, showing the soft tissue shadow in the roof and the posterior wall of the nasopharynx. So provisional diagnosis is adenoid hypertrophy. So treatment for this adenoid hypertrophy is, if it is causing the symptoms, severe symptoms, the treatment is surgical treatment. So mild to moderate hypertrophy with the mild symptoms during the upper respiratory tract infection, then you should try for the antihistamines and the decongestants to relieve the nose block. So severe symptoms means patient or child will have the continuous open mouth breathing and snoring and high arched hard palate, and also it leads to the eustachian into blockage and the non-suppurative otitis media. That this is the one of the commonest cause for the development of the NSOM, that is the non-suppurative otitis media or serous otitis media. So in those cases, we should go for the surgical treatment, that is the adenoidectomy. So this is the fourth X-ray. So symptoms of acute and chronic sinus, chronic adenoiditis, adenoid phases. What are the features you will see in the adenoid phases? Management of acute and chronic adenoiditis, crescent sign. So this is important in adenoid X-ray. What is crescent sign? How will you differentiate between the anterocranial polyp from the nasopharyngeal mass? So in this X-ray, if you observe, there is no air column between this skull base and the posterior wall of the skull. Suppose if you are able to see this kind of air shadow between the skull base and the posterior wall of the skull, then that is called the crescent sign. That means that is the anterocranial polyp. The mass is arising from the maxillary sinus and extending backwards into the nasopharynx, so that you should be able to see some air shadow between the roof and posterior wall of the nasopharynx. So that is called the crescent sign. If you are able to see the crescent sign or air shadow between the skull base and the posterior wall, that means that is the mass is arising from the nasal cavity and extending into the nasopharynx. So management of adenoid hypertrophy. So fifth X-ray. So here you can see there is a foreign body in the thoracic inlet, or you should count this vertebral column around the C6, C5, C6, C7 level. So this is the AP view and this is the lateral view. So this is again plain X-ray, neck and chest. Here you can see the neck and chest. This is the neck. So first X-ray is the AP view, second X-ray is the lateral view. In AP view, you can see the round radio-opaque foreign body in the esophagus. In lateral view, you can see the heads-on view. Heads-on view and end-on view are the two different points. So if you see the heads on view in the lateral view, that means the foreign body is in the esophagus. And also you can see the air column, clear air column in front of the soft tissue opacity. So this air column is larynx and the trachea. This is the epiglottis and this is the hyoid bone. This is the laryngeal area and this is the trachea, just below the larynx, trachea. So if the foreign body is present in the air column, that means the foreign body is in the larynx or trachea. If it is in the just in front of the vertebral column in the soft tissue shadow, so that means foreign body is in the esophagus. So the commonest site for the foreign body esophagus is cricopharyngeal sphincter. That is the starting point of the esophagus. That is the narrowest spot. Usually you will see these foreign bodies in that region. So treatment is you have to remove the foreign body under general anesthesia by using the endoscope. Okay, under general anesthesia, so sorry for the interruption. These are the other X-rays. It's foreign bodies in the esophagus. So here you can see again foreign body, chicken bone or mutton bone. This is also one of the commonest foreign body in the adults. Usually coins you will see in the children. So this is again sharp needle in the cricopharyngeal sphincter, the upper part of the pharynx. Okay. This is again a shaped nail in the esophagus, a ring in the esophagus. This is the foreign body in the trachea. Here you can see the safety pin in the trachea. This is at the level of the larynx. There is an open safety pin at the level of the larynx. This is the hyoid bone. You can see in the AP view it is an edge-on view in case of the trachea and the larynx. So in lateral view you can see this clear foreign body in the air column. That is the open safety pin. This is the screw in the bronchus. Here you can see the opacity, collapse of the lung on the left side. So these are the related questions. How will you differentiate between the foreign body of the esophagus and the trachea? Common foreign bodies in the esophagus and the trachea. Complications. Management of foreign bodies in air passes. Indications of esophagoscopy and the bronchoscopy and complications. So usually you will keep these 5 X-rays in your final examination. Okay, students.
Yes, sir.
Okay, just a minute. I'll take the instruments class. Chanakya, are you able to see the PPT?
Yes, sir.
Okay. So last class already told about in detail about the instruments. What is this instrument? Are you seeing any instrument in this picture? Students, roll number 7.
Yes, sir.
Yeah, are you seeing any instrument?
Yes, sir.
What is that surgery?
I don't know, sir.
You don't know.
Is it adenoidectomy, sir?
Tonsillectomy.
Tonsillectomy.
Tonsillectomy. See here, there is a hypertrophic tonsils. Okay, what is the position of tonsillectomy?
Rose's position, sir.
Yeah, rose position. Okay. So in rose position, we'll place the pillow under the shoulder and the head should be down compared to the chest. So that is to prevent the aspiration of these secretions from the oropharynx and the nasopharynx into the lower airway. So this is the endotracheal tube. Here you can see the loop of wire and the cuff. So this is the cuffed endotracheal tube. Tube is fixed to the oral cavity. And here you can see the one instrument to open the mouth. So that is the Boyle-Davis mouth gag. Here you can see the two structures, these two instruments. This is the plate to support these two stands. This is called the biparts, Draffin's biparts. This is the Mageran's plate. So these three instruments will use during the adenoidectomy and the tonsillectomy to widely open the mouth. So this is the Boyle-Davis mouth gag with different sizes of the tongue blades. So depending upon the age of the patient and size of the oral cavity, we should select the proper size tongue blade. Okay, this is the Boyle-Davis mouth gag. So this instrument will use useful for the any oral cavity or palate surgery or the oropharyngeal and the nasopharyngeal surgeries. So these two are the Draffin's bipart and the Mageran's plate. This is the Mageran's plate and the Draffin's bipart. So other types of this mouth gags, usually will not use these mouth gags. And this is the second instrument which we will use in the tonsillectomy, that is the tonsil holding forceps. Dennis Brown's tonsil holding forceps. So during the tonsillectomy, dissection and snare or coablation method, we need to hold the tonsil and we need to pull the tonsil medially and the posteriorly towards the posterior pharyngeal wall, so that there is a reflection of the mucosa over the tonsil to the anterior pillar. So there will give the cut. So this is the Dennis Brown tonsil holding forceps. So even though the name of the instrument is forceps, but the jaws are the not sharp. Upper jaw sits within the larger lower jaw. The edge of this forceps is very smooth, so that it will not damage the soft tissue while you will hold the tonsil. So this is to hold the tonsil during the tonsillectomy, that is the Dennis Brown tonsil holding forceps. So these are the forceps, toothed and non-toothed forceps. Here you can see the sharp tooth. This is the toothed forceps and this is the non-toothed forceps. This is also, these two also will use during the tonsillectomy to give the nick over the mucosa during the dissection and snare method, and also to keep the cotton packs into the tonsillar fossa after removal of the tonsil. This is the tonsil dissector. So the name of the instrument is Mollison's tonsil dissector, tonsil blunt dissector. So this is the blunt edge and this is the hook. So this edge will use for the dissection of the tonsil from upper pole to the lower pole. On this part will use to retract the anterior pillar after completion of the tonsillectomy, so that to inspect the entire tonsillar fossa. Okay, after tonsillectomy, we need to inspect the fossa for the any bleeding. This is the straight artery forceps and the curved artery forceps, Negus curved artery forceps. So these two instruments will be used to control the bleeding after tonsillectomy to hold the bleeder, usually paratonsillar vein in the tonsillar fossa. First we will catch with the straight artery forceps, then we will apply the curved artery forceps. Then we will apply the loop of thread around this curved artery forceps. Slowly we will remove the curved artery forceps. So that is to apply the knot in the tonsillar fossa. This is the suction cannula, anchor suction cannula. So this is also during the surgery to suck the hemorrhage and secretions from the tonsillar fossa. We will use this wide bore suction cannula. The name of the suction cannula is anchor suction cannula. This is the tonsillar snare. Here there is a loop of wire. So to open, we'll open this loop of the wire and then we'll pass the tonsillar mass through this loop of wire. We'll apply the lower pole region, this tonsillar snare. So this is the Eves tonsillar snare. So this is the St. Clair Thompson's adenoid curette with guard and without guard or case. So the position of the patient, everything is similar to the tonsillectomy and endotracheal tube intubation, throat packing. So we'll do the throat packing before starting the surgery. That is also to prevent the aspiration of the hemorrhage. Then we'll use to curate the adenoid. Adenoidectomy is usually done by the curette method. The other method is coablation. So during this curettage method, we'll use these two instruments. So this is the St. Clair Thompson's adenoid curette with guard or with case. This is the case or guard. This is the without case. Initially, 2 or 3 times we'll use this with guard instrument. Finally, without guard instrument. So this is the access forceps for the septum fracture, nasal septum fracture. This is the Walsham forceps for the nasal bone fracture. Here you can see the rubber covering over the one prong. This will come over the external nose. Then we will reduce the fractured nasal bone. Walsham forceps, access forceps. Walsham for the nasal bone, access for the nasal septum. This is the Tudicum nasal speculum. Usually we will use in the OPD, outpatient department, to examine the anterior nasal cavity. So here we will hold with the thumb and index finger. These are the prongs. We will close during the insertion into the nasal cavity. Then we will open so that we can widen the anterior nasal cavity. You can see the structures in the anterior part of the nasal cavity. This is one more nasal speculum, Killian's long bladed nasal speculum. So during the surgical treatment of the nasal septum, other nose surgeries to widely open the nasal cavities and also to see the structures in the entire nasal cavity, we will use this speculum, Killian's long bladed nasal speculum. So by using this instrument, we will infiltrate the local anesthetic into the nasal septum and also we will use this for the elevation of the flaps, nasal flaps. This is if there is any nasal spur, we will use this goose and hammer. This is the goose and this is the hammer. This is the Lux forceps. This is also similar to the tonsil holding forceps, but the edges are very sharp. We will use during the septoplasty to remove the deviated part of the nasal septum. That is the Lux forceps. This is the double-ended elevator, 3 years double-ended elevator. So this is we will use during the elevation of the mucosa over the nasal septum. This is the Hartmann's dressing forceps. This is the Tilly's dressing forceps. Hartmann's will use for the ear and Tilly's for the nose. So if you observe the edges of these forceps, here there is a flat surface. This is the sharp and with serrations. So Tilly's to pack the nose. That is for the anterior nasal cavity dressing. Tilly's dressing forceps. Hartmann's for the ear. So this is the self-retaining hemostatic mastoid retractor, Mollison's. So this will use to retract the skin and subcutaneous tissue in the post-auricular region during the mastoidectomy to expose the mastoid antrum region. Mollison's self-retaining hemostatic mastoid retractor. This is important. So you have to tell the complete name. So to retract the skin and subcutaneous tissue, and also it will reduce the bleeding by pressure. That's why that is the hemostatic mastoid retractor. This is the other instrument, periaster elevator. This is also used during the mastoidectomy. This is the curette, Lempert's curette, to curate any air cells disease process in the mastoid antrum and the air cells. This is the cell seeker. So to confirm the mastoid antrum and the air cells, before we will pass this part into the mastoid antrum and the air cells. These are the, this part is the curette and this is the seeker, cell seeker. Mastoid grooves we are not using these days. We will use the microtrill. This is the myringotope. So to make the incision over the tympanic membrane in case of ASOM and the NSOM, we will use this instrument, that is the myringotope. This is the oral dressing forceps. This this is the tongue depressor, lax tongue depressor to depress the middle third of the tongue during the oral cavity examination and the oropharynx examination. We will use this tongue depressor. And this is the direct laryngoscope. What we will do in the OPD is the indirect laryngoscopy, where we will use the mirror. So we will see the indirectly the structures in the larynx. This is the direct laryngoscope. So this will have the light source carrier here. So there is a illumination of the light here. You have to put the light source carrier here, so that you can see the structures in the larynx and hypopharynx. If there is any lesion, you should take the biopsy by using this instrument, and also upper part of the esophagus, you can remove the foreign bodies in the cricopharyngeal sphincter region. So these are the other types of the direct laryngoscopes, and this is the esophagoscope. So foreign bodies in the esophagus will remove by using this esophagoscope. This is the rigid esophagoscope. Okay, rigid esophagoscope under general anesthesia will remove the foreign bodies by using the rigid esophagoscope. So usually there is one more type of the esophagoscope, that is the flexible esophagoscopy. To examine the esophagus, to rule out any pathology in the esophageal region and the stomach, they will use that is used by the gastroenterologist. Flexible esophagoscopy, that is usually done by using the local anesthetic. So this is the tracheostomy tube, Silver-Jackson's tracheostomy tube. This is having the three parts. This is the obturator or guide wire, and this is the inner tube, and this is the outer tube. Always inner tube is the longer than the outer tube, so that the secretions will collect into the inner tube. Silver-Jackson's tracheostomy tube. This is one more type of the tracheostomy tube, cuff tracheostomy tube. So that this is the one more type, Fuller's tracheostomy tube. Here there is an outer tube, there is an opening. So this will help for the production of the voice. And inner tube also there is a slit here, vertical slit. So this is the Fuller's tracheostomy tube. With this instrument, patient can talk by using this tracheostomy tube. This is the tracheal dilator. During this tracheostomy, we will use this tracheal dilator. So this is the Trougius tracheal dilator. So these are the hooks, sharp hooks and blunt hooks during the dissection of the, during the separation of the layers from the skin to trachea. We will use these tracheal hooks. This is the indirect laryngoscopic mirror. Straight mirror we will use for the indirect laryngoscopy, so that we will see the structures in the larynx and the hypopharynx. This is the posterior nasal mirror or posterior rhinoscopic mirror. This is compared to that mirror. This is the bent mirror. So we should face this mirror towards upwards behind the soft palate, So then focus the light so that you can see the posterior part of the nasal cavity structures. This is the Jobson horn probe, usually used to clean the ear for dry mopping of the external aortic canal and also to remove the foreign bodies in the external aortic canal and wax remover. This is the tuning fork. These are the parts of the tuning fork: prongs, stem, and the foot piece or base of the tuning fork. So that is about the instruments in ENT and the X-rays. Students?
Yes, sir.
Okay. So almost we have completed the syllabus. Today I am giving the 5 important questions in the nose. By next class, all of you should write the answers and be ready with the answers, so that we will ask randomly any roll number. They have to read the answers. They have to answer these long questions. So I am giving the 5 long essay questions from nose. Already you have written the year. So all of you write down these questions. First question is anatomy of nasal septum, signs, symptoms and treatment of deviated nasal septum, that is DNS. You have to write in detail by seeing the textbook and be ready with your notebooks by next class. We'll ask randomly. If you answer these questions, then only we'll give the attendance. And all these attendance we are taking into consideration to send you to the final examination. So attendance is important. So tell your friends also, those who are absent today. So you have to attend the online classes. We are taking the attendance along with the internal marks. These two are the eligibility criteria to send you to the final examination. Otherwise, you will be detained in the final examination. So the first question is anatomy of the nasal septum, signs, symptoms and treatment of the deviated nasal septum. Second question is what is atrophic rhinitis, etiology, pathology, signs, symptoms and management of atrophic rhinitis. Etiology, pathology, signs, symptoms and management of atrophic rhinitis. Third question is what are the signs, symptoms and management of allergic rhinitis? You have to write the definition, signs, symptoms, management. Management means you have to write the investigation and treatment. So in treatment part, you have to write the both medical and surgical treatment if there is any surgical treatment. Fourth question is what is nasal polyp? Define nasal polyp. What are the types of nasal polyps? Etiology, clinical features, diagnosis and management. This is the fourth question. Fifth question is differential diagnosis of unilateral nasal mass. Etiology, clinical features and management of ethmoidal polyposis. Etiology, clinical features and management of ethmoidal polyposis. So these are the 5 questions you have to write in detail by seeing the textbook. Be ready with your notebooks by next class on Tuesday. So you'll ask randomly by roll number wise. You have to unmute yourself so you can open your notebook and you have to read the answer. Then only you'll get the attendance. Okay?
Yes, sir.
Students, have you written all the 5 questions?
Yes, sir.
Okay. Tell other students also, those who are absent today, they have to ready with these 5 answers by Tuesday. Okay?
Yes, sir.
Okay.